Good morning. I'm Dr. Richard Wender. I'm the chair of the Department of Family Medicine and Community Health at the University of Pennsylvania, and I'm really pleased to have this opportunity to talk to all of you today about how we can reduce the burden of colorectal cancer around the world. And what I'm going to talk about today is the importance of matching the strategy to the risk for colorectal cancer in the communities that are being addressed and the capacity to tackle screening and treatment. Here are the summary of my main points. First, the United States experience, when you look at it over several decades, is highly instructive about the current and future colorectal cancer trends around the world. Second, the risk of developing and dying from colorectal cancer varies dramatically between different countries, and it's important to know the risk in your local area. Third, specific criteria must be in place before embarking on a screening program. And fourth, matching a colorectal cancer control strategy to the risk and capacity in your local area offers the best opportunity to cost-effectively reduce the burden of colorectal cancer. So let's start by looking at colorectal cancer mortality trends in the United States heading all the way back to the year 1930. Let's walk through it together. You'll notice that in the beginning part of this trend line, 1930 to about 1950, was a period of rising colorectal cancer mortality for both men and women. In the next period, mortality stabilized in men and started to go down in women. This decline in mortality in women in the United States is still a bit of a mystery. No one quite understands why mortality started to go down in women, but stayed stable in men during this time period. I think the stable mortality trend in men is probably the more instructive line, since we don't really understand what contributed to this decline in women. Starting in the 1980s, colonoscopy was introduced and it starts to become more common. And you'll see it's in that period following the advent of colonoscopy access and then the beginning of a formal screening program that we see a far more dramatic decline in both incidence. And now we start to see a decline in male mortality as well as female mortality, with both incidence and mortality going down. In the United States, however, and it's not going to be unique to the United States, this is going to be an issue around the world, wherever you're practicing, we see disparities. Now, this particular graphic shows disparities relative to race and nationality, with the highest mortality seen in Alaska Indians, American Indians and Alaska Natives, but also seeing higher mortality in the Black population, which is in that kind of fuchsia colored line. I think we can also learn a lot by looking at socioeconomic disparities in cancer mortality incidence and survival in the United States, again, spread out over a long period of time. It's very instructive for what we're seeing around the world right now. This is the graph coming right from the Ahmadine Jamal article that I just showed you. As I like to say about this graph, it's everything you need to know about cancer disparities in a single graphic. Here are 7 key observations from that figure. So if you go back to 1950, you'll see that disparities based on wealth were actually greater in 1950 than they are today. There's a bigger gap. Each one of these lines represents a quintile of wealth. And the line at the top, the black line, was actually the wealthiest quintile group, and the orange line at the bottom was the poorest. So we did see very large disparities, with the wealthiest individuals having the highest death rate, which a lot of people find surprising. If you look in the wealthiest group, mortality remained largely unchanged in this from 1950 to around 1986. But during the same time period, cancer mortality was steadily rising in every one of the poorer quintiles, not in the wealthiest group. And then there was this kind of remarkable moment that most people don't realize ever existed, that in 1988, there was essentially no cancer mortality disparities in the United States based on wealth. But cancer mortality was high in every one of the wealth groups. It's important to remember that. We eliminated disparities, but not in a good way. It really was cancer mortality coming up to a very high point in all the groups. And that was followed by a critical moment that reflects the modern pattern where the lines crossed each other. Cancer mortality started to fall in the wealthiest quintile, but continued to rise in the poorest groups. And then in the very last segment of time, we see that cancer mortality in the United States is falling at a roughly equal weight in all the wealth groups from 2000 to 2014, but there's a persistent pattern of disparity with the poorer group having higher mortality than the wealthiest group. So here's what we can learn that's relevant to every setting in the world. First, why were cancer death rates associated with wealth in 1950 as opposed to associated with poverty? And the answer is that during this early period of the century, cancer was a disease of affluence, and mortality in 1950 reflected the behaviors of the population from 1900 to 1950. Cancer was associated with longer life expectancy. If you lived longer, higher risk of developing and dying of cancer. Was associated with tobacco use. And in the early part of the century, tobacco was a habit used more frequently by wealthier individuals, and only later did everyone start to smoke. Now it's more common in poorer groups. Caloric intake higher in the wealthier group, more red meat and processed food in general in the wealthier group. Overweight and obesity associated with more caloric intake, and physical activity was more common in the poorer group because they were doing the types of jobs that demanded more physical activity. And then we have this moment I mentioned where cancer disparities are eliminated, but we eliminated them in the wrong way. Everyone in all the subgroups faced a very high risk of dying from cancer. And for those who lived in the United States, you may remember that it was during this period that we predicted that cardiovascular disease would be passed as a cause of death by cancer, and that cancer would become number one. It's something that never happened, actually. Cardiovascular disease remains a leading cause of death overall in the United States. We have this critical period from 1988 to 1995 where mortality started to come down, but only in the wealthier group. So what explains this reversal in cancer disparities, where cancer mortality started to go down in the wealthier group, but not in the poorer group? Well, partly it was smoking. It's true that people with a college degree, also associated with higher wealth, gave up smoking at a more rapid rate and a more complete rate than people with lower education and lower wealth. And this had a profound impact on the overall cancer mortality lines, mainly due to its impact on lung cancer, where you see a very similar pattern. Cancer mortality was higher in the wealthiest group and then reversed and became highest in the poorer group as white men and wealthier men gave up smoking earlier in time. White men have higher obesity than Black men. Black women in the United States have the highest obesity rate. But the point is these patterns are changing, and that has contributed to this reversal of the lines in cancer mortality. So until 1990, cancer mortality trends were dominated by lifestyle factors, which in turn were related to wealth, income, race in the United States, ethnicity, and other social factors. But it was around that time that a new tool in the fight against cancer emerged that has been a game changer, and that is cancer screening. And you'll see that in the period following the advent of mammography on the left, We saw dramatic changes in the mortality pattern from breast cancer, where pretty quickly in about 7 years after mammography was first recommended in the United States, we started to see a decline in mortality in white women, whereas mortality in Black women continued to go up for many years and started to come down much later, leading to this very high gap in mortality of 45%, which just more recently has come down to 40%. We saw the same thing in colon and rectum cancer, where actually mortality was higher in the white population than the Black population. And then in the post-screening era, the white population benefited immediately. Took many years before we started to see a decline in the Black population. And if you're not familiar with the demographics in the United States, it's not a perfect surrogate, but in general, the Black population has lower educational achievement and lower wealth due to many societal and historical factors, which are not positive factors, but reflect health realities. So what are the lessons that can be learned for lower resource nations from this 100-year history in the United States? The lessons are that lifestyle and wealth will be associated with your colon cancer risk. So what are the criteria a country should meet before they consider starting a colorectal cancer screening program? And this first criteria is critical. The burden of the disease must be high. Second, colonoscopy access must be sufficient. Third, effective surgical treatment must be available. And fourth, the institution or organization responsible for the health of the public, such as a health ministry or a public health department, must be willing and able to invest in a population-based screening program. So you have to begin by measuring the burden of disease. And frankly, no country, no community should embark on a screening program without being very familiar with the burden of colorectal cancer in their local arena. And this is where the United States lesson is so instructive, because colorectal cancer incidence is strongly associated with behaviors. And these behaviors, traditionally in the United States, but now around the world, are in some way related to level of wealth as well as cultural factors. So what is the rate of tobacco use? How does that relate to poverty, income, and wealth? What is the pattern of caloric intake, overweight, and obesity? Is that, as it is now in the United States, more common in the poorer population, or where calories are really restricted, you're going to see a much lower rate of overweight and obesity, and it's associated as well with a lower rate and a lower risk of colorectal cancer. What is the consumption of red meat and processed foods? In societies that are dependent on foods that are grown, locally produced, not processed, the rate of colorectal cancer will be lower. What's the rate of alcohol use? Another risk factor. And something that we're learning more about is what is access to antibiotics, because frequent antibiotic use may also be associated with colorectal cancer, higher risk as people age. In fact, this is exactly what we see around the world, that there's quite a substantial variation in colorectal cancer incidence and mortality. If you look at the top, you'll see the incidence curves, which are highest in Europe, even though they have screening, Australia, Canada, and then some of the South American countries and Asian countries are in the next group. In part, United States had a very high risk, but have also had very successful screening programs, which reduced incidence. And if you look in mortality, you'll see both the lowest incidence and mortality are in poorer countries, particularly in sub-Saharan Africa, with only a few of the more wealthy African countries in the north and south having incidence and mortality comparable to places like the United States, some areas of South America. So please be aware that colorectal cancer incidence varies considerably between countries. The incidence, for example, in the United States is approximately 36 per 100,000, Whereas in Nigeria, just one representative country in sub-Saharan Africa, it's 3.4 per 100,000, dramatically different rate, 10 times more common in the United States. And even between sub-Saharan African countries, you'll see important variations in risk. So you have to ask yourself, if we're going to consider screening, is the burden of colorectal cancer high enough in our country to make a screening program a good investment? The second thing you have to look at is colonoscopy access, because that is the single most important component of a screening program. Here's why it's so important. Although the population-based colorectal cancer screening program starts with a non-invasive, affordable stool test, preferably a fecal immunochemical test, although you can use a guaiac fecal occult blood test as well. The fecal immunochemical tests perform better. You have to understand that everyone with a positive test must complete colonoscopy to realize any benefit at all. Doing a stool test, getting a positive result that's not followed up by colonoscopy will result in no benefit whatsoever. Even in countries like the United States, where we do a lot of colonoscopy and our access is high, the variability in colonoscopy access remains one of the leading sources of disparities in the United States. So how can you calculate colonoscopy need in a screening program? This simple calculation is pretty close to how you can figure out what the need will be. Depending on the incidence of colorectal cancer in the population and the choice of the fecal immunochemical test or other stool tests that's used, somewhere between 0.5 and 5 individuals per 100 over 50 years old will test positive on the stool test. So that means that screening 100,000 people in a year would result in the need for somewhere between 500 to 5,000 colonoscopies per year. So the lessons here are that it's very important to know what the risk of colorectal cancer is in your local area so that you can calculate what the colonoscopy need will be. These higher positivity rates, 5 per 100,000, are only seen in settings with a very high colorectal cancer burden, such as an unscreened poorer population in the United States. You might get as high as 5 per 100,000. But in most countries and in most communities, the positivity rate will be somewhat lower. Finally, it's important wherever you live and whatever community you're serving, that you make an effort to prioritize interventions that are designed to reduce colorectal cancer mortality, whether or not it makes sense to initiate a screening program. So one of the first places to start is to make sure that everybody who's providing healthcare and the general public is educated about so-called red flag signs and symptoms for the earlier diagnosis of early onset colorectal cancer. This is looking specifically in younger people, but a very recent article just published this year, but I think the results are relevant for older population as well. And what the authors found is that red flag signs and symptoms that are associated with colorectal cancer are abdominal pain that's persistent, rectal bleeding, which should not be ignored or dismissed, diarrhea, one we don't always think about, and iron deficient anemia. So those are the red flag signs and symptoms, and everybody, certainly the clinicians caring for patients, should be aware that people presenting with these symptoms probably need a colonoscopy to find out if they have colon cancer. The next thing that is vitally important in an effort to reduce mortality is to make sure that surgical management of high quality is available, because the best opportunity to cure colorectal cancer is generally through high quality surgical management. I am not dismissing the importance of modern day chemotherapy, immunotherapy, wherever the trends are going. But remember that patients who have metastatic disease are unlikely to be cured of their colorectal cancer. The best opportunity to cure somebody is to find them in a stage of the cancer, preferably 1 or 2, rarely stage 3, that might be curable through surgery. So developing the capacity to perform the surgery should be a top priority in every country. So what are my suggestions for how we can move forward to tackle the burden of colorectal cancer around the world? And I think in every country, high resource and low resource and middle resource, we have to confront the reality that avoiding all disparities in cancer outcomes is extremely difficult, probably impossible. There are always subpopulations that have higher resources, better access to care, who are likely to benefit from advances in cancer care earlier, more quickly than populations with lower access, lower resources, and who are less likely to receive the highest quality care. That means that when you introduce something new, whether it's a new treatment, a new drug, or a new approach to screening, some populations are likely to benefit earlier than is the entire population. And I think it creates this very difficult conundrum in cancer care. One choice is to basically stand still, not introduce anything new, but work on narrowing disparities for the cancer care that is available today. Or the other choice is to move forward, always being ready to introduce something new that might be more effective, but then do everything we can to ensure that everyone benefits as quickly as possible from the remarkable advances in cancer care that are emerging now. And I believe we must keep marching forward. If we have the opportunity to test out a screening program in a wealthier part of a population that has better access to care, we can use that as a chance to really refine and learn how to screen that population, make sure colonoscopy is available, figure out how to disseminate stool testing, how to get it into people's hands, how to make sure they return that test, and how to make sure that people with a positive result get into colonoscopy as quickly as possible. But we then must be committed to taking the lessons learned and ensuring that everybody in a whole nation or in a broader community benefits from what we've learned from those smaller pilots. So together, I believe we must move forward with deliberate, coordinated efforts to minimize the emergence of disparities and to shorten the period where only some people benefit from the advances that we're seeing. Thank you so much for listening to this presentation. I really look forward to getting your responses, your thoughts, and your questions. Thanks again.
It was such a wonderful presentation that you gave. Thank you so much for, the high level overview and, for the use of layman terms, right? Because so often we get these presentations and they're kind of like high tech and hard to understand. So I really appreciate you really making sure that you drove home and it was understandable. And so I really want to hone in on, one of the last things you said, which was about the surgical management. And I recently found out how important that was. And I didn't really understand the context by how that impacts your survivorship, right? So can you expound a little bit more on that, and especially for for our neighbors who actually may not necessarily have access to great surgical management, and maybe, are there suggestions, just can you kind of walk us through that a little bit?
Yeah, I'm not a surgeon, so
Yes.
I'm a family doc, and but very committed, as you know. Obviously, Candace, you and I have worked together for years, trying to address the burden of colorectal cancer. Um, but there are data showing that the level of experience that a surgical team has in caring for people and operating on people with curative intent surgery, the goal to cure the cancer. Uh, that the success of that surgery is dependent on the experience of the team. So um, I think we have to accept the reality that there are in some settings, the only surgeons available are general surgeons, and they are doing every operation there is to do. And there are training programs available for that are run by subspecialists, colorectal cancer surgeons that can go over technique. And I think if a surgeon in any setting is the person who's going to be called on to do curative intent surgery for people with colon cancer, uh, they at the very, very least should try to participate in some sort of mentorship or training program to see where techniques are going. Um, Obviously, if there is access to people who, concentrate surgery in high volume areas, you should do it. And that may even be possible in places where there are fewer surgeons. You may take different cancer surgeries, for example, and say, listen, we're going to send all the colon cancer surgery and all the rectal surgery is particularly demanding. And even in the United States, we really encourage people to get to a center for rectal cancer. The surgeries are tough and complicated. But if you're in a lower resource station, when I say lower resource, just in terms of number of surgeons, at the very least, trying to concentrate that surgery in a fewer number of surgical teams, I think, is a smart move.
Gotcha, gotcha. Awesome. Thank you so much for expounding on that. Like I said, I just recently found out how important it is. So, and then when
Yeah.
you touched on it, I was like, oh, great. So here's a great opportunity. So I have a couple of questions for you. So one of the questions said, if roughly 4% of the US population will get CRC, how is it 36 per 100,000?
They Well, it's not 4% who develop it. It's 4% who have a positive fit.
Okay.
So of those who have a positive fit, most of those actually will have a polyp or will not have cancer. So it's a maximum of 5 out of 100,000 that will test positive in a screening population. Of those, not all of them have cancer. So, uh, but that's what's necessary when you do a fit-based screening program. Again, as I said on the talk, if that does not result in colonoscopy, there's no hope of benefit. I mean, that's how we find the polyps. That's how we find the cancers. Interestingly, the most common finding after a positive fit test is a polyp. It's actually not cancer. And people occasionally will use the term, well, fits don't detect polyps, but um, in some cases, it's probably incidental. The bleeding, the positive fit wasn't due to the polyp, but it still leads to colonoscopy. And the most common finding is a polyp, not cancer. So remember that our goal through a screening program principally is to prevent cancer, not to just find curable cancers. So uh, that's why there's a difference between what the rate is in the population versus how many colonoscopies you need to be prepared to do in a fit-based program.
Gotcha, gotcha, gotcha. Okay, so looking at the history of cancer disparities, and you mentioned that in your talk on about how in the 1950s, how the wealthiest group, right,
Yeah.
had the highest rate, and then it transitioned. So when we start looking at things like that, and the swapping, of the way that it's going, how do you think that's impacting our disparities that we're experiencing today? Do you think that that is contributing to what we're seeing, not just here in the US, but globally?
Yeah, it's such a fascinating picture, and it's an interesting story with a lot of lessons. I actually went to a talk probably 30 years ago where it was a very learned talk, but I don't think I appreciated it at the time, and it was really talking about this shift in from as wealth across the world increased, we shifted cause of death from being predominantly diseases of infancy, uh, childhood death, maternal death, infection related death. But as people became wealthier, more access to care, they lived longer. And there was a real shift away from infectious causes of death to cardiac and cancer as the major causes of death. And in a way, the whole world is in that somewhere along that spectrum right now. And wealth has increased very substantially in almost every country, including the poorest areas of the world, like sub Saharan Africa. Uh, and with wealth increase, that doesn't mean people are wealthy,
Right.
just means the increase in wealth. You also see a shift in behaviors. Uh, there had a strong association that used to be seen in the early days of tobacco. It was a habit that wealthy people use. Now it's kind of shifted. We see higher rates in poorer populations, and there are many different types of tobacco products. and a real shift in caloric intake, meat intake, cheese intake, overweight, and obesity. So um, and a shift away sometimes of high fiber foods, which may have a small protective effect. It's not a major one, but a small protective effect. More access to antibiotics in childhood, which may have a small effect as well, change the microbiome. So this, I'm not sure I love the term westernization.
Right.
I tend not to use that term much. It's just a shift in that's probably principally associated with the wealth of the population, but the so-called westernized diet, westernized habits, et cetera, result in often cases fewer deaths from malnutrition, some of the infectious causes. You have cleaner water, people live longer, but then you're inevitably going to shift the risk to these chronic diseases, cancer being and heart disease will gradually start taking over, and we are seeing that all around the world. That as life expectancy increases, you'll see a higher rate of cancers. Now, how does your real question, of course, was disparities, um, and it's such a refractory problem, Candace, because we will often use the term we're going to eliminate disparities.
Right.
I am not aware of any real strong examples where we figured out how to eliminate them. Although it is amazing, in 1988 in the United States, there were no disparities based on wealth. There were still disparities based on where you lived. There were still higher mortality rates in Black and Hispanic populations, in American Indian, Alaska Native. So it wasn't, this was just based on wealth. There were none. But as I said in the talk, in the wrong direction. Yeah, there were no disparities, but the rates were incredibly high. So I think we have to be committed to driving mortality down, recognizing that every new advance is actually going to contribute to disparities. And we just have to not just, I don't mean to minimize how serious a problem this is. We have to own the fact that new advances are likely to benefit people who have more rapid access and
Mhm.
based on where they live, their insurance in the United States, or just access to the highest level of care. But measure that, determine it, make sure that what we're doing is working, and have a commitment to try to minimize that period where disparities emerge. Uh, Most countries aren't doing a great job of that. It's and in the United States, we are certainly not. I mean,
Yeah.
it's pretty stunning that there were, if you look at black-white disparities in the United States, there were no black-white disparities for breast cancer and colorectal cancer until we started to screen.
Mhm.
That's when the disparity of 40% mortality disparity emerged. So we got to own it.
Yeah.
Um, that when we do something new, if we're not very deliberate and very thoughtful, you're going to see huge disparities that may take decades to bridge, unless you start planning for that from the start.
Yeah, right. So it's like well-intended consequences can sometimes have disastrous results, right? So I mean, we
Yeah,
know that in the age of precision medicine that it is, I mean, it has the ability to be a game changer. But if everyone can't access it, it's
yeah,
almost like, what's the point of having a swing set in the backyard if there's no kids playing with it, right? So we have all of, this data and information about how great this can be, but if we don't have people to have access to it, is it really great? You know what I mean? You know, so and especially now in when we're looking at the landscape changing with colorectal cancer to early age onset. So
yeah,
we have a question. Um, it states that I in the UK, many younger people are being diagnosed with stage 4 colorectal cancer. My
yeah,
own daughter died at 31. Doctors told her she was too young to have bowel cancer. I
yeah.
support many younger people stage 4 palliative care in the UK. Is this the same globally? And why can younger people not get screened if they have symptoms?
Yeah, it's such an important question, and thank you for asking it, and thanks for sharing your story.
Right.
These personal stories are very powerful and tragic, but we also need to learn from them. So, uh, the question of why colorectal cancer incidence is moving younger is probably the central research question in front of the world right now. Probably nothing more important. It's multifactorial. Uh, Diet is playing some role. I mentioned antibiotics. There's new factors that are being searched for that explain this shift to younger ages. It is being seen around the world, but it is clearly seen more in the higher resource nations just because their risk for colorectal cancer is already higher. But we are seeing this dramatic shift. And I do lots of talks, as you know, Candace, about this shift to younger ages, and can't say strongly enough how the screening age needs to shift to 45 as it has done in the United States, and it needs to in many other high resource nations. Frankly, personal prediction, not based on guidelines, I actually think it will shift lower in the next decade if these trends continue, even to 40. Number two, any patient with, here's what my mantra is, very simple. Anybody can develop any cancer at any age. Anybody can develop any cancer at any age, and certainly colorectal cancer at any age. Therefore, symptoms of colorectal cancer, and that's why I put those red flag symptoms up there, of abdominal pain, diarrhea, rectal bleeding, iron deficient anemia. Do not make up some explanation. Well, you're young, it was probably hemorrhoids. Well, did you actually see hemorrhoids? No, we didn't see hemorrhoids, but it was probably hemorrhoids. These patients, we need to pull the trigger. And listen, I'm a family doc. I see this in my own office. And sometimes I go, you know, patient looks healthy, they look well, but I don't pause. If I see someone with rectal bleeding unexplained, they go for colonoscopy. So that's not called, technically, that we don't call that screening. Then screening is by definition an asymptomatic population. So, but patients with symptoms, diagnostic testing, absolutely. We need to keep doing a better job with the public, a better job with clinicians, pounding this message home. It's still frustrating that we continue to hear stories where these symptoms were delayed 6 months, 9 months, 10 months, which may have made a difference in the end.
Yes.
As far as screening is concerned, it would be great to be able to screen everybody. No nation, no community in the world has the capacity to screen everybody. And if you screen people where the risk of colorectal cancer is extremely low, you're taking resources away from other important health problems and dedicating them to a screening program that's going to have minimal benefit. That doesn't mean zero, minimal. So we do have to pick the perfect age where it makes sense to start screening.
Awesome. Awesome. Thank you so much, Dr. Wender. Your presentation was amazing. We truly, truly appreciate your time and would love to have you back, and we can talk more about your presentation, because I really want to talk more about the 1988 wealth
Got you.
gap.
All right.
Awesome. Thank you. Bye-bye.
Thanks, Candace. Bye-bye. Thanks, everyone.
Thank you.